Hello, everyone. I'd like to welcome both new and old friends to this first of a series of webinars based on the recent and wonderful Asian Oceanian Epilepsy Congress held in Delhi in February. As we all know, as we strive to help our communities with epilepsy, education and forming our Asian Oceanian Epilepsy community is so important. And we can do this by face-to-face meetings as well as webinars like this. And between this first and the last of these webinars in late June, some of the highlights and the education of the Congress are going to be covered. And this first session on inflammation, epileptogenesis and epilepsy, I'm sure, like me, you'll find wonderful speakers educating us and bringing us up to the cutting edge of this very important topic. So I will finish by welcoming you all and hoping that in addition to seeing you on the internet, we'll be meeting face to face in your homes for education and community, helping the community with epilepsy. Thank you.
Thank you, John. John has already mentioned about this webinar. First of all, I extend you all greetings from New Delhi, India, where this seminar was held in the month of February of this year. Very successful meeting, and we have highly educative content, and we updated our knowledge. Now, out of that, 5 webinars have been extracted, and we will be covering the first webinar of the series of 5. This will run into June and early part of July, and we'll show you the highlights of those webinars. And the first in the series, as he mentioned, is the inflammation, epileptogenesis, and epilepsy, covering like autoimmune encephalitis, leading to epilepsy, and other relevant topics. Let us all update our knowledge, including myself, and I'm sure you will enjoy this academic program, and Q&A and your responses will be very helpful to further improve the webinars. So once again, grateful to ILA for keeping these 5 webinars. And please do spare time to attend. I know time difference may be there, but it is worth attending and updating our knowledge. So with this, once again, thank you to all the delegates who will be attending this webinar and benefiting in their further enhancement of knowledge. Thank you so much.
Thanks so much, John and Man, and thank you to the ILA for organizing this. So I'm Derrick Chan, and I'd just like to straight away start introducing our first speaker. So this is Professor Divyanshu Dubey, and he's a professor of neurology, co-director of the Neuroimmunology Laboratory, and clinical chair of the Laboratory Services and Partnership Development at the Department of Lab Medicine in the Mayo. And he's also, his research interests focus on central and peripheral autoimmune neurological disorders and the discovery of novel biomarkers, not least of which include CALCH11, LUTS-P2, and CAVIN4. And he's got over 200 publications. So without further ado, we'll have the video, and then we'll be having a few minutes for question and answer from Professor Dubey, who's kindly joined us from Rochester. Thank you.
The talk today is going to be predominantly clinical. The goal of this talk is for us to leave with some idea about what these autoimmune epilepsies or autoimmune seizures look like. I wanted to go over the spectrum of these disorders, started from autoimmune encephalitis with associated seizures, and potentially towards the end, talking about some pure epilepsy presentations without a lot of features of autoimmune encephalitis. These are some of my disclosures. We've discovered some antibodies. I will talk about a few of them. I'm not going to go in depth into treatments or trials, so some of the industry disclosures might not be relevant. So again, the overview of the talk is, as we all know, sort of as we delve into the field of epilepsy, the terminology keeps changing. We've started to kind of get that feel even in the autoimmune literature. We keep coming up or keep ourselves employed by coming up with new terminology every few years. Secondly, we'll delve into individual antibodies, and what I want you guys to kind of leave with is some idea about, are there clinical clues which can help us not only say this particular patient might have an autoimmune etiology, but can we narrow it down further, which sometimes is not as easy, but what type of antibody could this patient have? So one of the kind of the important landmark position papers in the field of autoimmune neurology was this 2016 article, which talked about diagnostic criteria for autoimmune encephalitis. I think it's a very useful paper for all neurologists, including people who are focusing on epilepsy, because it talks about diagnosing patients of autoimmune encephalitis as the workup starts, not once you have done treatment down the line, 6 months down the line. The possible criteria doesn't even require you to have the results of the antibody. So you can have patients who meet these criteria, which can help you identify, are these the right kind of patients for you to do further investigations, consider immunotherapy, etc. And then there are multiple different sub-criteria, most of them emerging from that possible autoimmune encephalitis criteria, and then talking about definite autoimmune encephalitis, seronegative probable autoimmune encephalitis. So extremely useful study for us clinicians to know about. Using this particular study, we also wanted to understand how important is autoimmune encephalitis on a sort of an epidemiological scale. So we conducted a study in Olmsted County, Minnesota, where Mayo Clinic is based, where we calculated incidence and prevalence of autoimmune encephalitis. And Olmsted County is, in some ways is blessed in a way that we know electronic medical records of every single individual, pretty much every single individual who lives in Olmsted County. So when we do incidence prevalence studies, we don't even have confidence intervals because we can say this is the prevalence of disease. And comparing autoimmune encephalitis to infectious encephalitis, again, keep in mind this is Minnesota, not New Delhi. The prevalence of autoimmune encephalitis was comparable or similar, some actually slightly higher. The important take-home message here being autoimmune encephalitis is not as uncommon as we initially expected or suspected it to be. The second message was the incidence rates were rising, and most of the rise was coming from antibody-positive cases. Is it because we're having an epidemic of autoimmune encephalitis? I believe not. I think it's because we're recognizing these cases more because the antibody testing is becoming more prevalent and more people are using it. And then if we extrapolate this data on a worldwide stage, there are about 1 million patients who have autoimmune encephalitis, and there are about 90,000 people who develop autoimmune encephalitis every year. So once again, highlighting that these are not, conditions are not as rare as what we initially suspected them to be. Moving on from encephalitis to now sort of the epilepsy focus, because not all of these patients would have epilepsy. We are doing a subsequent study focusing on incidence and prevalence of autoimmune seizures and epilepsy, and close to half to 60% of these patients do have seizures, and then we have collected additional patients over the last few years. So hopefully I'll be able to share that data in the near future. But the terminology of autoimmune epilepsy has become much more complex now. We just don't use the word autoimmune epilepsy. Depending upon the presentation, the two terms which have been suggested are acute symptomatic seizures secondary to autoimmune encephalitis or autoimmune associated epilepsy. I see the idea behind these terms, especially the acute symptomatic seizures secondary to autoimmune encephalitis, highlights that these patients that we are dealing with who come into our hospital who are encephalopathic, confused, have dysautonomia, and are presenting with seizures, may not have lifelong epilepsy. These patients might be having seizures like our herpes simplex encephalitis patients only when the brain is actively inflamed. A good example of this is NMDA receptor encephalitis patients, MOG patients, which we'll briefly touch on. The autoimmune-associated epilepsy, the way it was initially described, was primarily talking about patients who have a T-cell-mediated disease, like GAD65, the high-risk paraneoplastic antibodies. But subsequent commentary by one of my colleagues, Dr. Bien, talked about even in patients who have antibody-mediated epilepsy, such as LGI1 or Casper2, at one particular time point, a subset of these cases transition to autoimmune-associated epilepsy when the inflammation is gone and what people are left with is mostly injury. This is the time when you do MRIs and MRIs look fine or normal. Or PET scans do not show active inflammation. CSF profiles are not significantly inflammatory. These are some of the cases who are coming to you all for surgery evaluations and may have actually an antibody-mediated disorder to begin with, which subsequently transitioned to chronic drug-resistant epilepsy. So I think these terminologies are helpful, give us an insight into how we're going to treat the patient, especially with anti-seizure medications. Moving on from terminology, now thinking about individual antibodies. One of the most common ones, which I encounter in my clinical practice, is LGI1. This is probably the most common autoimmune epilepsy, autoimmune seizure I see as an outpatient, which is antibody-mediated. It's a disease more commonly seen in men, and what is being cut by that video, and I'll correct that for my next talk, is these patients are usually older. They're more than 50 years of age. I have a spectrum from sort of early 50s to all the way to late 90s as far as the age presentations are concerned. There are a few pediatric cases, but they are far and few. The one TIF seizure type we're all aware of associated with LGI1, and I think it's starting to make into some of the board questions as well, is facial-brachial dystonic seizure. So I'm going to show you this video, and you'll all think about facial-brachial dystonic, but I want you to look at something else along with that, and that's the leg. So you saw that it was not just the dystonic movement of the hand and the face, and I'm going to try to see if I can play this again. There's also dystonic movement of the leg. And imagine if somebody is going through and having 150 of these in a day. They can happen while somebody's walking, somebody's biking, or they're just sort of going up and down the stairs. So asking about the leg and recognizing how significantly this can impair the functioning is very critical. Hence the word facial-brachial crural dystonic seizures is probably more appropriate. And it's something which we've seen in about up to half or 50% of the cases with these type of presentation. The other seizure semiologies that we are aware of are pilomotor seizures, multifocal sensory seizures, which are very hard, very difficult to diagnose. These are patients we are sending back from the emergency room. And then ictal bradycardia. I had a patient with ictal bradycardia who required a pacemaker, even though we could tell this is sort of ictal in onset. Initially, when this entity was described, people used to think this is a monophasic disease. You hit them with steroids, give them seizure medications, send them home, they'll be fine. And now we understand up to 1/3 of patients have relapses, highlighting why we need to treat these patients chronically. And some of these patients, especially patients who have lesional epilepsy, who have pretty significantly inflamed limbic system on MRIs, those are the ones who go on to develop chronic epilepsies, and that might be a marker of delayed diagnosis, because when the disease starts, MRI looks fine. If you follow up these patients and get a scan down the line and not treat these patients, you'll start seeing asymmetric T2 flare hyperintensities in these cases. Again, some of the fall work, which has been done by a couple of my fellows, Dr. Lee and Dr. Gupta, shows how important recognizing that crural movement of the leg involvement is. These patients can have injuries ranging from ICH to subarachnoid hemorrhage to lacerations from these falls, and learning how this disease is not just about seizures, it's about cognition, it's about falls, it's about sleep dysfunction, is kind of making us sort of think about disease-specific outcome measures. So this is some work which we are doing using rash analysis, where Xiaoyang and Pranjal are really being instrumental in collection of data and subsequent analysis, where we are trying to generate a LGI1 outcome rating scale. So when I'm talking to industry about let's do a clinical trial on this disease, I'm not telling them the only thing we can use is modified Rankin scale, because that's not at all appropriate for this disease. So hopefully LGI1 outcome rating scale would give a better idea of how this disease truly behaves, and some of the spaghetti plot that you can see down here sort of gives you an idea how this is a chronic active disease which doesn't just subside after the first few months. It's an ongoing process, and these patients often require treatment for an extended period of time, which Dr. Chang will probably tell us about in his talk. Moving on from LGI1 to Caspr2. Before I talk about Caspr2, that's another take-home point for us to remember. Voltage-gated potassium channel antibodies is not useful. We should not be testing for these. Majority of patients who are positive voltage-gated potassium channel antibodies and negative for LGI1 and Caspr2 do not have an autoimmune disease. So please do not give them immunotherapy or do serial PET scans. Now moving on to Caspr2. Caspr2, initially when it was described back in 2010, the main association was peripheral manifestations with neuromyotonia, ISAC syndrome, Moore-Van syndrome, which also had some central presentations as well. But as we've collected more and more data, we've recognized that pure central manifestations, specifically epilepsy, is a common and important manifestation of Caspr2 autoimmunity. Interestingly, not only in our study, but in other studies as well, nearly everybody who has Caspr2 epilepsy or Caspr2 associated autoimmune seizures are men, older men, the median age was even slightly higher than the LGI1 patients. Most present with focal onset seizures with altered awareness. Very interesting seizure semiologies. We've talked about that in this particular epilepsy paper. And a high proportion of these patients go on to have at least episodes of secondary generalization. But the thing to remember, because there's no facial brachial dystonic seizure which will make you think this is a Caspr2, or like a particular seizure semiology which will say, aha, I've diagnosed a Caspr2 patient. But what will help you diagnose a Caspr2 patient is firstly the demographics, and secondly, not another cause, but then the coexisting manifestations. These patients can have episodic emotional lability. Many of my Caspr2 patients kept telling me about, I go from happy to sad in just seconds, without a significant event which would kind of explain it, without a significant trigger. I'm watching television and then all of a sudden I start crying. Some of sort of a pseudo-bulbar kind of an affect, but this is very episodic, raising concern for is there an ictal phenomena going on. There's also this description of paroxysmal dizziness, and I know my residency mentors would hate me for using the term dizziness, but it's very hard to describe. This is not vertigo, this is not lightheadedness, but they have this sort of odd sensation or a dizzy sensation that they talk about, which is also brief. Again, could this be ictal? And then episodic gait instability and ataxia, which has been described in Caspr2 autoimmunity, but can coexist with seizures. So if you're having a patient with focal seizures who has some of these neurological manifestations, think about Caspr2. Then another caveat or thing to remember with Caspr2, low titer Caspr2 results are often misleading, and these patients often don't have autoimmunity. And that's one of the limitations of some of the the more commonly available commercially based testing that we utilize by fixed CBAs. So our lab, after this experience of this paper which we worked on, has changed our reporting rule to now we test at the lower titer or screen at the lower titer, but all the reports also go out with the higher testing results, saying if you're only positive at 1 to 100, that usually has a strong association with neurological autoimmunity. Briefly touching on MDA, we all know about an MDA. We have seen patients, hopefully, in the inpatient setting with an MDA. It can present with seizures. It's a perfect example of acute symptomatic seizures secondary to autoimmune encephalitis. These patients, most of these patients don't go on to develop chronic epilepsies. More than 80% have seizures up front. 6 months down the line, I take them off anti-seizure medications when the EEG doesn't show anything concerning. Some of them can present with status epilepticus, non-convulsive status epilepticus up to begin with. So if your patient is altered and having sort of in the ICU, think about hooking the patient up to see if the patient is having any seizures. There's some pediatric studies talking about particular semiologies, such as unilateral dystonic tonic posturing, followed by a post-ictal TORDS-like phenomena. That's been seen in pediatrics. I have not seen that too much in the adult cases, but that's something to think about. There's a lot of sort of talk about delta brush, but we don't see a lot of delta brush. The other thing is delta brush is also not specific to an MDA. I've had hepatic encephalopathy patients present with delta brush as well. So again, don't think this is not the facial brachial dystonic correlate of an MDA. MRIs are usually not very useful in MDA receptor encephalitis. There's some studies from our Hopkins colleagues, and then sort of one of the collaborators I'm working with in Canada is also about to publish some data about PET being useful in an MDA, specifically showing occipital parietal hypometabolism. And then touching on one of the antibodies, which is now sort of more commonly encountered for both good and bad reasons, because there's a high rate of false positivity with low titer MOG cases. But one particular semiology which seems to be very specific to MOG is unilateral cortical encephalitis or cerebral cortical encephalitis. One of the first studies was done by our colleagues in Japan, Dr. Ogawa. They talked about unilateral involvements with asymmetric T2 flare hyperintensities. Some of our recent work done by one of my previous fellows, Dr. Montalvo, we built on this by talking about it's not just unilateral, it can be bilateral or asymmetric bilateral. We talked about seizure semiologies, which can be often focal motor seizures going on to secondary generalization. And then a subsequent paper talking about pathology showed how the pathology of cerebral cortical encephalitis mimics or resembles what we see in MOG with sort of some demyelinating features along with axonal loss. It's something which radiologists often miss, unfortunately. So it's, as neurologists, this is another example of for why it is important for us to go look at the MRIs ourselves to make sure that somebody who's presenting, or especially a kid who's presenting with status epilepticus or new onset seizures, doesn't have this. Very treatable if diagnosed early, and most of these patients don't go on to develop chronic epilepsy. So cerebral cortical encephalitis, followed by sort of these flurry of papers, was also included in the recent international MOGAD diagnostic criteria. So it's a thing now. So we should probably hopefully catch some of these cases, diagnose, and help some of these kids. Moving on to from antibody-mediated conditions to now T-cell mediated disorders. These are conditions where the antibodies are very useful. They help us diagnose these patients, but these antibodies are not causing the disease. So if you're giving these patients FcRn therapies or immunoabsorbing these patients, you're not really doing them much good. What helps these patients is immunosuppression, where you can stop the T-cell mediated attack to the particular putative autoantigen, which in many of these cases, as we have demonstrated, ends up being the same as what is being targeted by the antibody. One of the greatest examples of this is GAD65. We think it's a T-cell mediated disease, similar to what we see with type 1 diabetes, but it's a very, very difficult disease to manage and often diagnose as well, because the onset happens many, many years before you end up seeing the patient and sending the GAD65 results. So I suspect, similar to type 1 diabetes, even though even in that case we know it's clearly an autoimmune phenomena, we don't treat it with immunotherapy because immunotherapies don't work because the pancreatic islet cells have been destroyed. I think unfortunately something similar happens to those neurons as well. Most of these patients do not have any MRI abnormalities. The CSF looks bland. Interestingly, many of these patients present with multiple different seizure semiologies, some of them also with reflex semiologies, which I'll briefly talk about, and the immunotherapy is rarely useful. So these are the site of cases where when I was early on in my sort of early faculty days, I was super excited and I was giving them from anything from tocilizumab to cyclophosphamide. Now I've become much more conservative. I do an immunotherapy trial up front for IVIG or IV solimodrol, depending upon whether they have type 1 diabetes or not. And if that 12-week immunotherapy trial does not show improvement, I don't push further for additional immunotherapy because I've not seen drastic results in these cases. One of the unique reflex epilepsy cases that we saw encountered at Mayo was during the period of last 20 years where we had electronic medical record to search from, there were only 16 clear-cut musicogenic reflex epilepsy cases that were seen at Mayo. And among 9 of these, for some reason or another, the epileptologist had sent serum samples to our lab. So I pulled some of these samples. Some of them were already tested for GAD65, but I pulled some others and tested them. And lo and behold, every sample of these patients, every particular patient was positive and had high titers of GAD65 antibodies. And we described this sort of autoimmune musicogenic reflex epilepsy phenomena. Interestingly, it seems to be very unique to GAD65. I still don't know why. And again, to make sure that I was not just creating something which wasn't there, we also had a patient in the EMU with GAD65 autoimmunity whom we admitted, hooked up the patient up for EEG, and then played the music. So I'm not sure if we can play the music with the video. Or I think so, everybody can hear it. So even here, firstly, as I do not read EEGs, but even I can see there's a seizure which is starting. You can see the oral automatism starting. Patient is not following commands. On the left side, but able to follow the commands on the right. Most of these musicogenic reflex epilepsy cases have a right temporal ictal onset. There are a wide variety of musics that we see see this from. I'm still learning all the genres of music, but I've not necessarily seen that only with the hip-hop music we see with seizures. One of the most frustrating cases I saw in January was a young 30-year-old girl who had musicogenic reflex epilepsy, and guess what her profession was? She was an orchestra player, and her husband is also an orchestra player, and the only kind of music which leads to seizures is the one her husband plays, which is a very specific type of music. But again, hopefully we'll be able to help her so she can go back to her profession. Another set of T-cell mediated diseases are those which are associated with paraneoplastic antibodies. So many of us who work in this field came together in 2019, I think as we were getting bored with not doing much in pandemic, and decided to update the paraneoplastic diagnostic criteria. So we had a brief meeting, Dr. Draus, Dr. Dalma, a few other people in Lyon, followed by sort of coming up with a list of what all has happened in the last 20 years. And one thing which has happened in the last 20 years is a bucket load of new antibodies. So instead of using the term onconeural antibodies, which came up with this term high-risk paraneoplastic antibodies, these are antibodies with a very strong cancer association. Most of these antibodies are not pathogenic, but they cause disease, which is T-cell driven disease. So I wanted to look into what do these patients' epilepsies look like. And what we found was the take-home message here was most of these patients do fall into that autoimmune associated epilepsy bracket. If they are not treated very early in the disease course, they do end up having chronic epilepsies, which are refractory to immunotherapy. And most of this happens because the damage is already done. This is sort of more of that traumatic brain injury scenario where there's neuronal loss, and giving them more Cytoxan is not going to fix it. The things which we saw which were associated with chronic epilepsy were high seizure frequencies to begin with, irregular EEGs, classic limbic encephalitis with enhancement early on in the MRIs. This is an example of sort of some of the work which has been done by one of my fellows, Dr. Parmasivan, showing an MRI of an ANA1 or anti-Hu patient, initial limbic encephalitis with enhancement, and as time went on, there's more and more atrophy and injury. And then we are starting to look into biomarkers, which such as neurofilament light chains, GFAP, which can tell us if the injury is more significant, and it actually does correlate with worse outcomes with the elevation of neurofilament light chains. And then since I think that bell was to say I'm out of time, so I'm going to skip up some of these slides, 2 minutes. We've looked into other biomarkers such as T-cell activation studies to answer that question, is the autoimmunity still active? And then another area that our lab is actively focusing on is chemokines, cytokines, specifically in the areas of NORS and fires. Can these biomarkers be helpful not only to diagnose somebody, but also guide therapies? These are the patients to give IL-6 inhibitors to. These are the patients to give IL-1 inhibitors to. And then working with some of our South Korean colleagues, we've recently kind of identified that some of these cytokine profiles do correlate with long-term outcomes, especially correlating with MRI features and subsequently correlating with our long-term outcomes. And then as I come towards the end of the talk, the few things I would like to kind of leave the audience with is what are the clinical clues? How can we identify these patients in our inpatient, outpatient practice? This was a score which came out of a quality improvement project I was doing as a resident at UT Southwestern. Subsequently, we worked on it and refined it further. It's a score which can be applied even before you have antibodies or before you're sending antibodies to try and identify which patients are more likely to be positive. For individual antibody clues, there are certain things like we talked about in our talk. If the patient has facial-brachial dystonic seizures, think LGI1. If the patient has episodic emotional lability, think Casper2. Musicogenic reflex epilepsy, hopefully now we'll think more about GAD65, diagnosing these patients. Multifocal neuroaxis involvement, not just limbic encephalitis, but diencephalic involvement, brainstem involvement, spinal cord involvement. Think high-risk paraneoplastic antibodies like ANA1. And then NORS and FIRES, the antibody associations tend to be GABA-A and NMDA. And then radiologically, that's a good MRI example from MOG. So those fluffy-looking subcortical white matter lesions, cerebral cortical encephalitis, which are lining the cortex, can have coexisting brainstem involvement. LGI1 tends to be more typical classic limbic encephalitis without extension into the extralimbic structures. CRIMP5 can cause seizures. That tends to have more diencephalic, caudate, putamen involvement. MAR2 is more hypothalamic in terms of presentation. And this is a classic example of GFAP, whereas you see these periradial enhancing lines. Again, think about lymphomas as well in some of these cases, if the profile suggests that. And then finally, NMDA MRIs are not that helpful, but the PET scans are. So the take-home points are autoimmune epilepsy and autoimmune seizures are sort of being recognized more and more. I think some of the epidemiology stuff is suggesting that. Probably antibodies are one of the main factors why, and we will keep making the field more interesting by discovering newer and newer antibodies. There are a handful of them in the pipeline. Non-antibody biomarkers is probably going to be the next thing, which will start informing our diagnosis and treatment. These are neural engineering biomarkers, cytokine, T-cell assays. In terms of clinical practice, clues can come from some of the initial clinical presentations. You can apply models such as APE2 score. There are other scores called ACE score, which are also useful. And then look for those clinical radiological clues, which can help you diagnose these patients. If I'm seeing a facial-brachial dystonic seizure patient, I'm not waiting for LGI1 to come back 2 weeks later. I'm treating the patient then and there. So that's where the clinical clues are going to be helpful. With that, thank you.
So that's a fantastic talk by Div, and I think we've got a couple of questions in the chat for you.
Sounds good. I think the first question is what antibodies are associated with musicogenic reflex epilepsies. So far in my experience, the only antibody that I've seen which has a strong association with this serious etiology is GAD65. Most of these patients that we've encountered have super high levels of GAD in the serum, and nearly all of them who have been tested in the CSF were also positive in the CSF as well. I've not encountered similar semiologies with other antibodies, but I suspect you could have patients with just the right inflammation at the right spot in the right temporal lobe, potentially presenting with musicogenic reflex epilepsies, but so far I haven't seen it. The reason why these patients develop musicogenic reflex epilepsy still is unknown. It's a fascinating topic for further sort of research and discussion. And there's sort of an overlap between sort of neuropsychiatry and along with sort of ictal phenomena arising from the right spot. Another question there is in relation to the findings on inflammation associated brain fog in patients treated with CAR T therapy. Do you have any observations on the matter or practice? So we do, unfortunately, we are starting to see complications of CAR T therapy more and more, mostly in our inpatient service, rather than outpatient service. And some of these patients, in addition to having brain fog, they can go on to develop seizures, and they require treatment with sort of anti-seizure medications. But in addition to that, the phenomena of brain fog and especially seizures in these patients, which are classified as ICANS, is not necessarily antibody mediated or in some cases even T-cell mediated, but it's more the innate immunity which is driving the disease process. And one of the topics I talked about in my talk was utilization of chemokines and cytokines, and we started to do that more and more in these patients with sort of CAR T complications. And there are studies where we've sort of which have shown that utilization of medications like IL-6 inhibitors, especially in more refractory presentations of ICANS, it has been shown to be helpful in managing some of the patients with neurotoxicity. So we had used steroids, plasma exchange, and in some cases, even tocilizumab. But this is more related to more severe complications with seizure manifestations rather than just isolated brain fog. Another question from Dr. Shah is MOG with cortical encephalitis are different in prognosis. Is there data about relapse? Great question. I think the prognosis is the cortical encephalitis itself often does not relapse. If diagnosed early and treated, many of these patients do tend to improve, and some of them have complete resolution. The exceptions are very few. I've had a patient who sort of unfortunately was diagnosed late, already had a significant amount of injury and had incomplete resolution. In terms of relapses, most of the relapses I've encountered in these patients have been episodes of optic neuritis, which is sort of similar to what can be seen in ADEM patients, where even if the first episode is an ADEM episode or a transverse myelitis episode, most often the relapses are optic neuritis manifestations. Okay, I think I may have another minute or so for questions. I'll take a couple more. From my knowledge of literature, patients with chronic autoimmune epilepsy tend to have predominance of IgG4 subclass, like LGI1. Should positive antibodies be assessed for IgG subclasses in clinical setting and could predict responses? Another great question. So, but I would say it's not just IgG4. You're right. LGI1 tends to be IgG4 predominant. Even Casper2 in some scenarios tends to be IgG4 predominant, but that does not apply to antibodies such as GAT65. So even specifically for LGI1, I think there's a clear sort of an IgG4 mediated pathomechanism. There is some role of subclass testing. A study from Dr. Irani has demonstrated that if you have a higher predominance of IgG1 subclass compared to IgG4 subclass, the cognitive impairment tends to be more in these patients. So there might be sort of some role of subclass assessment, I think, but needs to be kind of evaluated further in additional studies to try and understand whether it will have clinical implications. And then last question, in cases of autoimmune encephalitis caused by NMDA antibodies with normal EEG after acute phase is resolved, can some type of epilepsies develop later? I suspect they can, depending on the extent of injury, neural injury up front. But in the majority of the cases, I would say more than 80% of patients with NMDA receptor encephalitis, they usually present with seizures and status epilepticus up front. And oftentimes when you treat these patients acutely, the seizures tend to resolve. And these are the patients I actually take them off anti-seizure medications 6 months down the line once the encephalitis itself has resolved. There are a couple more questions. What I'll do is I'll try to answer some of these questions through the chat so we can move on to the next talk. Okay. Dr. Chan, do you want to introduce the next speaker?
I think, yeah, certainly. So I think we're very pleased to have our next speaker. 1 second, sorry. Oh, sorry, my phone's just gone into sleep mode for a second. Yeah. So I think we're very pleased to have Dr. Jyotirmoy, sorry, I may have mispronounced that, Jyotirmoy Banerjee, who's additional professor of biophysics and in charge of the Epilepsy Neurobiology Laboratory. And he's at the All India Institute of Medical Sciences at New Delhi, India. And his area of interest is aberrant synaptic transmission in drug-resistant epilepsy. So we'll go straight into his talk, and then we'll have a little bit time of question and answer after that. Thank you very much.
So, very good afternoon to all of you here. At the onset, I'll like to thank the organizers to welcome me in this beautiful meeting. Today, I'll be speaking on the basic science perspective of inflammation with respect to various drug-resistant epilepsy pathologies. Before I go to the details of my presentation, I just want to mention that I don't have nothing to disclose. So, as of all of you are aware that drug-resistant epilepsy is present in about 1/3 of the patients with epilepsy. And there are multiple hypotheses which has been proposed so far for the mechanism associated with drug-resistant epilepsies. There are 6 major and widely accepted hypotheses so far. One of them is neural network hypothesis, which suggests that the abnormal network generation is mediated because of the neuronal death, and the remaining neurons generates abnormal neuronal network that contributes to drug resistance. Another one is intrinsic severity hypothesis, which suggests that there is, with increase in the seizures, there is increase in the severity of the drug resistance. And then we have the genetic variation hypothesis, where it has been shown that the receptors and the protein molecules which are present on the membrane of the neurons have genetic variabilities associated with polymorphisms. And then we have therapeutic target hypothesis, which is actually similar to that of genetic variation, where the targets are actually dysfunctional, because of which the anti-seizure medication doesn't work on these patients. Then we have drug transporter hypothesis, where it suggests that increase in the transporter levels in the blood-brain barrier doesn't allow the concentration of these anti-seizure medication reach the targets. And then a similar hypothesis is pharmacokinetics hypothesis, where it suggests that the levels of, or the concentration of the anti-seizure medication which is needed is not there in the central nervous system. But none of these hypotheses are actually thoroughly taking into account all the neurobiological process, primarily because all of them are interconnected. Genetic variation hypothesis, as I mentioned, is directly linked with the therapeutic target, where the polymorphism in the targets could be contributing, or the pharmacokinetics, where the transporters are having polymorphisms. Then intrinsic severity hypothesis is associated with neural network hypothesis. But connections among these different hypotheses are so complex that unfortunately, in isolation, we can't use any of these hypotheses to prove that there is drug resistance. And one of the major component to drug resistance mechanism is inflammation, which in most of the cases, most of the hypotheses are involved but are not much talked about. So can inflammation could be a connecting link between these hypotheses? So before I move into the different inflammatory mechanisms, I'll just briefly describe the blood-brain barrier integrity. As you all are aware that this is the neurovascular unit which is responsible for the blood-brain barrier, and it is made up of endothelial cells, the pericytes, the end feet of the astrocytes, and the neurons. And the integrity is primarily maintained in this blood-brain barrier by the tight junction proteins. So what happens during seizures? It has been shown that these tight junction proteins becomes dysfunctional, because of which there is release of the inflammatory molecules into the central nervous system, which are responsible for activation of the glial cells. And these glial cells are then further involved in release of metabolites and molecules, which enhances the hyperexcitability mediated by various neuronal receptors. So just to briefly tell you about the factors which are contributing to inflammation and which are mediated by the glial cells, the astrocytes, and the microglia. There are various mechanisms which has been proposed and has been reported, which suggests that there is impaired water and ion buffering. Primarily the potassium ions. The buffering of the potassium ions are responsible for increased repolarization. Then because of the inflammatory mechanisms, there is increased reduced glutamate clearance. And this reduced glutamate clearance is responsible for increase in the excitotoxicity, which is primarily mediated by the glutamate receptors. And then we have gap junction uncoupling. Gap junctions are primarily responsible for maintaining the potassium ion buffering, as well as release of the neurotransmitters, as well as the inflammatory molecules. And these gap junctions are primarily made up of connexins. These connexins are hemichannels. These hemichannels forms the gap junction. And there are reports that most of the connexins in the central nervous system, in case of drug-resistant epilepsy pathologies, there are alteration in the functioning of these connexins. There will be a talk on the connexins, especially on this aspect by one of our lab members tomorrow, so I'll not go into the detail for this in this talk. And this is just to summarize the role of the glial cells in blood-brain barrier dysfunction and inflammation. As I mentioned, after the damage of the blood-brain barrier, there is activation of the glial cells. There will be secretion of the inflammatory mediators, primarily the pro-inflammatory cytokines. And these pro-inflammatory cytokines are contributing to increased hyperexcitability. And the central and peripheral inflammation in drug-resistant epilepsy pathology are kind of segregated. And it has been reported that it's not just the glial cells, but in fact the neuronal cells also contribute to the inflammatory mechanisms. There are changes in the neuroanatomical structures of the neuron, which are contributing to various hyperexcitable condition, but they are also simultaneously contributing to the inflammatory mechanisms. So increase in the spine density has been reported. Increase in the length of the apical dendrites of the pyramidal has also been reported, and all of them significantly contribute to the inflammatory mechanisms. And one of the recent topics which has been widely discussed suggests that the gut microbiota, we have the, of course, in a simple term, we have good and bad bacteria in the gut which are contributing to seizure generation, but some of these species are responsible for inflammatory molecules, and it has been shown that ketogenic diet has been very, very helpful in reducing the inflammation in some of these patients. There are few reports on that. And I mean, although not much has been talked about the neuroinflammation hypothesis, but recently Lucier has suggested that the neuroinflammation hypothesis could also be contributing to the drug-resistant epilepsy mechanisms, and they might be interrelated with the other hypothesis which has been mentioned, because inflammatory mediators, which are not only limited to the cytokines, but other non-mutually exclusive pathways could also be contributing to this phenomena. And for the understanding of these phenomena, the preclinical resources are very, very helpful. And in our laboratory, what we are doing is we are using various preclinical resources for understanding the hyperexcitability and the inflammatory mechanism which are actually contributing to hyperexcitability in various drug-resistant epilepsy pathologies. So I'll just briefly give you some idea about the resources that we use. Primarily, we are working on resected brain specimens which are obtained from patients of drug-resistant epilepsy pathologies who are undergoing epilepsy surgery, resective surgery. And we obtain these targeted samples which are being collected directly from the epileptogenic zone. And the epileptogenic zone, I'm sure all of you are aware, are identified using multimodal imaging techniques. And once these resected brain specimens are resected, we bring it to the lab, we perform various physiological and multi-omics approach to understand the mechanism of hyperexcitability as well as inflammation. In addition to that, we also have various animal models for drug-resistant epilepsy pathologies. Today, I'll be primarily speaking on our findings from two of the animal models. One of them is for focal cortical dysplasia, the BCNU rat model, and another one is the lithium pilocarpine model for temporal lobe epilepsy. So I'll start with our major findings on mesial temporal lobe epilepsy. So as I mentioned, we collected the hippocampal as well as the extrahippocampal samples from the patients of mesial temporal lobe epilepsy who are undergoing surgery. And we measured the glutamate receptor currents. Initially, first to understand if there is any abnormality at the neuronal network level, at the neuronal level. So for that, we used a technique which is called as patch clamp technique, where we can measure synaptic activity right from the neuron, and we have done this from the resected brain specimens obtained from these patients. So as you can see, we have seen that in MTLE patients, there was increase in the glutamate receptor function, as suggested by the increase in the frequency and the amplitude. And further, we found that the mechanism of these glutamate receptor alteration is different in the hippocampal and the extrahippocampal structures, which suggested there could be two different networks possible there in the hippocampal as well as the extrahippocampal region. So this suggests there is abnormality at the neuronal network level. Then we further looked into the molecules that are contributing to these changes. We found that the glutamate receptor subunits has been altered. And then this gave us an idea that let us go into more detail and see the neuroanatomical structures. And what we found was at the neuroanatomical level also, both in the animal models as well as in patient samples. I'm just showing here over the animal model data. We found that there is increase in the apical and basal dendrite length. Also, there was increase in the spine density. So this further corroborated with our findings that there is network level changes at the neuronal level that are responsible for drug resistant in TLE. To further understand the mechanism of hyperexcitability, we did transcriptomic analysis of these brain samples. We did the RNA sequencing. And I would like to mention here that this is the first study on the resected brain specimen on which transcriptomic profile was done. And we found that there are certain molecules which are altered in these MTLE brain samples. And we found that one of the major molecules was FN1, which is fibronectin. And this fibronectin plays a very, very crucial role through its integrin and NF-kappa B mediated pathway in the inflammation and inflammatory mechanisms. So this finding gave us an idea that how the molecules which are altered at the transcriptomic level are contributing to the inflammatory mechanisms. There was another molecule which was casein kinase 2, which was also altered, and we found out that casein kinase 2 also contributes significantly to the inflammatory mechanisms through Wnt-catenin pathway. And this Wnt-catenin pathway has long been studied for its role in inflammation in epilepsy. Then another important finding that we got from these samples obtained from patients with mesial temporal lobe epilepsy was there is change in the tryptophan and kynurenine pathway metabolites also. As you are all aware that tryptophan kynurenine pathway metabolites are contributing to the regulation of glutamate receptor mediated hyperexcitability. One of the major molecules of this tryptophan kynurenine pathway was kynurenic acid. And this kynurenic acid was reduced in these samples which we got from patients, from hippocampal samples of these MTLE patients. This suggested that reduction in the kynurenic acid level could be one of the possible mechanism of hyperexcitability. And as there is increase in the hyperexcitability, there are chances that these kynurenic acid, which is also a regulator of GPR35, that is contributing significantly to the release of the inflammatory molecules. So we have simultaneously glutamate receptor alteration and inflammation regulation by kynurenic acid. So both the drug resistant, the drug target hypothesis, as well as the intrinsic hypothesis are contributing to this phenomena. There was one more study by one of the PhD students in our lab where we have observed that there is increase in the levels of the TGF-beta, which is a significant marker for inflammation in temporal lobe epilepsy. And we have also looked at the downstream molecules which are regulating the TGF-beta function, and that also were altered, which further helps in our understanding that how the inflammatory mechanisms associated with temporal lobe epilepsy, as well as which is present in the other drug-resistant epilepsy pathologies, could be contributing significantly to the hyperexcitability. One more study by one of the students, we found that there is alteration in the histone deacetylase levels, and one of the histone deacetylase subtype are contributing to inflammatory mechanisms. And there was, as I mentioned during in one of my previous slides, that one of the possible reasons for BBB damage is phospholipase A enzyme, and we found that the cytosolic phospholipase A enzyme was also altered in case of temporal lobe epilepsy. Then I'll briefly give you some information about our findings on the samples which we obtained from patients with cortical dysplasias, focal cortical dysplasias. In case of focal cortical dysplasias, what we found was there was alteration in the GABA receptor functions. As you all are aware that GABA receptors are primarily the inhibitory neurotransmitter receptors. But in this case, as focal cortical dysplasia is a neurodevelopmental disorder, it has been shown that there is dysmaturity associated with focal cortical dysplasia. And this dysmaturity is primarily mediated by the GABA receptors, which are actually here functioning as the excitatory receptors. So we have observed that there is alteration in the GABA receptor function, and this alteration, we thought that because of this alteration, there is aberrant neuronal network. But when we checked at the subunit level, we found that the configuration of these GABA receptors were altered. So that suggests that now the configurational changes in the GABA receptor subunits are responsible for the drug resistance. And we found that there is one subunit, which is the alpha-4 subunit of the GABA receptors, which are not sensitive to the benzodiazepine drugs, where their levels were very high in focal cortical dysplasia samples. So we have more of alpha-4 containing GABA receptors, which could be contributing to this phenomena. And further, we found some genetic variants also of these GABA receptors, which could be contributing to the altered GABA receptor function. And at the epigenetic level and the other genetic variability level, we found that microRNAs are also contributing to this phenomena of the GABA receptor function. And in a recent task force meeting of ILE, it has been based on our finding, they have suggested that these GABA receptor variants can be used as a predictor for drug-resistant epilepsy pathologies. So further to look into the mechanism of this altered GABA receptor function to the inflammatory mechanisms, as I mentioned, we found that there is increase in the alpha-4 containing GABA receptors. So these alpha-4 containing GABA receptor mechanism could be one of the possible reason for increase in the inflammation. So we try to find out that how that could be contributing, although we have not done much experiments right now on that, but there are few reports which suggest that increase in the inflammation could be responsible for increase in the levels of alpha-4 containing GABA receptors. So the inflammation mediated paroptosis. Paroptosis is a mode of cell death which is mediated by the inflammatory molecules. So we are proposing over here is that increase in the alpha-4 containing GABA receptors could be a possible compensatory mechanism for the increase in the paroptosis associated with focal cortical dysplasia, as well as in case of other drug-resistant epilepsy pathologies. And then what we did was we tried to identify the molecules of these inflammatory molecules which could be used as a possible marker for in a pathology-specific manner. So we tried to identify specific molecules which are present primarily in the temporal lobe epilepsies, or in case of cortical dysplasias, we identified few molecules, and we are still working on that if we can use them as a possible marker for in a pathology-specific manner. One of the finding from this study was that we have also identified certain microRNAs which are contributing to the inflammatory mechanisms. One of that microRNA was microRNA 223. So then we further looked into the mechanism of the function of these microRNA 223. There we found out that this microRNA 223 is responsible for the activation of the platelets. Now, platelets which are present in the peripheral system can be activated by the microRNA 223. And it has been shown that these platelets, which are activated platelets, they are significantly contributing to the blood-brain barrier damage. So we have checked the levels of these molecules which are released from the activated platelets. We found that the levels of the serotonin, which are responsible for inflammation via leukocytes and platelet activation, as well as the histamine, which are directly released from the platelets, they are also stimulating and significantly contributing to the inflammatory mechanisms. So our finding from the this platelet-based studies suggests that these platelets which are activated because of the inflammatory mechanisms, they can further enhance the inflammatory molecule release into the central nervous system. That will be further increasing the levels of the activated glial cells. Then these activated glial cells might also be significantly contributing to the receptor function, the ion channel function, and specifically the glutamate and the GABA receptor function. And that altered function will lead to hyperexcitability and drug resistance, primarily mediated by the altered neuronal network as well as the inflammatory mechanisms. As I was mentioning during one of my previous first slides, that one of the mechanisms that we have also which has been proposed is the genetic variability hypothesis, and the pharmacokinetic hypothesis, where the polymorphisms has been reported in the targets as well as the transporters. But unfortunately, this genetic variability hypothesis does not include the epigenetic variations as well as the variations mediated by the long non-coding RNAs as well as the microRNAs. So some of our studies, although this data is not published yet, but our findings from the long non-coding RNAs as well as the copy number variations that we have seen in some of the molecules are directly indicating their role in inflammatory mechanisms. As some of the molecules that I have shown here are basically the CNVs, the copy number variations, as well as the altered long non-coding RNAs, which are contributing to different mechanisms of whether it is through NF-kappa B, through TGF-beta mechanisms, as well as the oxidative stress mediated by reactive oxygen species. So all these mechanisms are significantly contributing towards the neuroinflammation, which is somehow looking to be linking the different hypotheses of the drug-resistant mechanisms. So based on our findings and as well as from the reports from various labs, can we use inflammation as a condition for drug-resistant epilepsy pathologies? So just to summarize what we have discussed in this talk today, we have inciting events both in the central nervous system as well as in the periphery. In the periphery, the inciting events might be contributing to the activation of the leukocytes as well as platelets. These platelets itself can damage the blood-brain barrier, which are basically the neurovascular unit there. And this damage will release the neuroinflammatory molecules that will further enhance the activation of the glial cells, the astrocytes as well as the microglia. And this increase in the glial activation are directly relevant to the inflammatory mechanisms. We have one more mechanism which has been proposed and it has been shown that there is a protein called P-glycoprotein, which is actually a transporter, and it's part of this drug transporter hypothesis. These P-glycoprotein levels are directly affected by increase in the inflammations. So increase in the inflammation, there will be increase in the P-glycoprotein level. That will definitely lead to reduced levels of anti-seizure drugs in the central nervous system. And the inciting events in the brain, which will directly lead to release of the cytokines, and that will activate the microglials and astrocytes and glial cells. That will in turn lead to the alteration in the synaptic activity, primarily mediated by the glutamate receptor and ion channels. And this will lead to development of the neuronal network. So based on this finding, what we are seeing here is that all the hypotheses which has been proposed so far for drug resistance are primarily interlinked to each other, and somehow the neuroinflammation hypothesis is possibly a connecting link between these hypotheses. Like neuroinflammation hypothesis can go very well with the pharmacokinetic hypothesis, as I mentioned, because of the P-glycoprotein data. Then it can be linked with the neuronal network hypothesis, where there is increase in the neuronal death mediated by neuroinflammation and the alteration in the synaptic activity and hyperexcitability. We have neuroinflammation can be related with the intrinsic severity hypothesis, where increase in the seizure generation will lead to increase in the inflammation. The neuroinflammatory mechanisms can be contributing to the drugs transporters, and the neuroinflammatory mechanisms can definitely target the various targets of the drug-resistant anti-seizure medications. So on this basis, we can propose that we need a global hypothesis which will include inflammation and may be established for our various drug-resistant epilepsy mechanisms. So I like to acknowledge our collaborators. We have a very close collaboration with neurosurgeon Professor P. Sarachandra, with Professor Manjari, who is a senior neurologist, Professor Ramesh, he is a senior neurosurgeon, Dr. Aparna, she is a molecular neurobiologist, Professor M.C. Sharma, he is a neuropathologist. And then whatever data which I have shown is the hard work of our PhD scholars, the scientists working in our lab, and most of them will be here in this meeting during next 3 days. And I'll also like to thank the funding agencies from various government agencies, Department of Biotechnology, ICMR, Office of Principal Scientific Advisor to Government of India. And I'll I'll also like to request all of you to visit our posters. We have a lot of posters from our lab, which will be linking our findings with the neuroinflammatory mechanisms. Thank you.
Next, we're going to have question and answers for a couple of minutes for Dr. Banerjee.
Maybe I'll ask a question. So, Dr. Banerjee, you mentioned that platelet dysfunction is potentially a factor in epileptogenesis. Are there any clinical features we can tell from the platelet count or the platelet morphology that could maybe help us, elucidate that better?
No, with respect to the platelet count, there are no reports as such. But yes, with respect to the platelet activation, there are suggestions that if some of the markers for the platelet activations are present, that could be a possible used as a possible marker for drug resistance.
And Dr. Another question that I had was, have you done the proteomics or similar biomarker work in sort of serum or CSF of some of these patients to potentially have some kind of prognostication in terms of drug-resistant epilepsy markers, which can also down the line help with therapeutics?
That is an ongoing work which we are doing. Basically, we have done some proteomic analysis of some of our resected brain specimens. We have identified some of the potential molecules. Now we are going back to the serum and checking if those molecules can be correlated with our findings from the resected brain samples. One of the molecules which we have identified was the cytokine molecules, especially the IL-6 molecule, which has been shown. So yeah, we are looking into that aspect. Yeah.
Thank you. I think we can have more questions at the end. So I'm going to go ahead and introduce the next speaker, Dr. Derrick Chan. Dr. Chan is an associate professor, a senior consultant in pediatric neurology, and a clinician scientist at Singh Health Singapore. His clinical research interests focus on immune dysfunction and epilepsy, and he also serves as the director of the Medical Technology Office. I'm looking forward to the very interesting talk of sort of immunotherapeutics and epilepsy. Dr. Chan.
Great, thanks so much. And it's a great privilege to be here today. You'll notice that my talk actually ends in a question mark because we don't assume to know everything that there is to know about this. I think the scene has been set beautifully by Prof. Dubey and Prof. Banerjee. So I'm just going to jump in with a little case study because these are my conflicts of interest. None of them are relevant, but I thought I'd jump into the clinical case just to keep you all fresh and interested. So this is a 3-year-old girl who presented to us. Completely normal past medical history, and she originally developed influenza A meningoencephalitis at another center. She had some red cells in her CSF, nothing in the white cells, protein wasn't very high, glucose looked normal, treated with levetiracetam, seemed to settle down. And then a couple of months later, she had seizure recurrence, thought to be occipital in onset. Her seizures got worse despite treatment, and then she turned up at our institute a couple of months later. And she was having 20 to 150 seizures a day. And she was already on multiple treatments, and we optimized the treatments. A colleague saw her, and understandably, with the basis of the seizures occurring in the context of meningoencephalitis, the thought of some kind of immune-mediated cause came up. So she got pulsed with methylprednisolone. She was referred to us, and then we saw her, we put her on topiramate, and then we said, let's do that EEG to see exactly what's going on. And for the EEGs among you, you'll enjoy this one. So this is her EEG as she starts having a seizure. And as we progress, you can see that she has this very high amplitude slowing on the right side, highest in amplitude posteriorly, which is understandable why it was thought possibly to be occipital. But if we look very carefully, the phase reversal of that slowing actually lies across F8 and T4, right? So we know in bipolar montage, the high amplitude just means maximal difference. So she actually had a very wide field, right frontal, ictal pattern. And the posterior bit is actually the quiet occipital lobe, reflecting that in the bipolar montage. So when we repeated her scan, and we were looking much more in the right frontal area, and this is what her scan shows. I'll give you a second to see if you can spot it. Yeah, I can see a couple of fingers pointing, right? Before, when you're looking at the occipital, you're like, I don't see it. But when you see it closer, when you know it's coming from the right frontal, there are these thickened and abnormally formed sulci in the right frontal area. And this was the origin of her seizures. And that was what was giving rise to such a wide, broad field of seizures. So we took her forward to epilepsy surgery. We did some ECOG to make sure we didn't, because it's a little bit deep, we wanted to check out the margins. Managed to remove that area, and she became seizure-free, and she's still seizure-free, weaned off most of her medicines a couple years later. So why do I mention this? It's because it's a very typical clinical scenario where you have a patient who maybe presents with this meningoencephalitis or a viral illness, some seizures, and it's really plus minus. It's not entirely clear, is this inflammatory, immune-mediated epilepsy, or is this some kind of or just a new onset, explosive onset epilepsy? So interestingly, she is a patient who actually has both. So she started with an inflammatory influenza A encephalitis, and then actually she turns out to be having basal sulcus abnormality, and then the refractory epilepsy. Now, the question that of course raises is, and you've already heard from our previous speakers, is whether inflammation is that final common pathway in epileptogenesis. That lesion has sat there for 2 years with no activity whatsoever, and only after she develops the encephalitis, suddenly she surges and starts to have these refractory seizures. And this is a very nice paper which, with a diagram which highlights the theory behind this, that it could be due to, well, either an early inflammatory hit or possibly some other underlying etiology, and that hit then gives rise to onset of seizures, and then it starts an inflammatory cascade. And then the seizures become self-perpetuating, and that buildup of an inflammatory cascade leads to seizures beget seizures, and you get more seizures, and then subsequently you'd start to develop a cognitive and behavioral impairment. And over time, you can move into the realm of pharmacoresistance, so drug-resistant epilepsy. Now, the concept of immune modulation in epilepsy is not new. We already use it very commonly. So infantile epileptic spasm syndrome, high-dose steroids, ACTH or prednisolone is standard of care. And we know neurosteroids aren't the cause of action because guanaloxone didn't really work in these patients. There are many people who also use steroids, high-dose steroids in refractory epilepsy, but this is a much less well-studied area. And we actually only have case control studies, 2 RCTs, one of which had only 2 patients, and very little strong data. No consensus on the type of steroids, the dose, the duration, or the patient selection. And really very little understanding on the no molecular studies with those treatments on what is the mechanism of treatment response when they do respond. Since this is a talk on basically therapeutics, so basically we will talk about the therapeutics that we do know we can give. So steroids in IESS is well known and very established. ACTH, there are various regimens, low dose and high dose regimens. Ricona et al. Showed that there didn't seem to be a very large difference between the different regimens or use of natural or synthetic ACTH. Prednisolone, a lot of us use the UKIS protocol with 40 milligrams a day for a week, and then 60 milligrams a day if they persist, and then tapering off. So these are very evidence-based, these are very proven, and they work very, very well. You've heard from Professor Dubey about antibody-mediated autoimmune encephalitis, and these are very well described now and very well recognized clinically. And you heard the excellent clinical phenotyping, which is so important to make sure that we clinically phenotype the patients well before we leap into the diagnosis and the treatment. And I like this by my colleague, Professor Tripathi, which emphasizes, sorry, it's kind of a little hidden behind, but yeah, basically emphasizes that clinical process and making sure that you have that suspicion, not necessarily waiting for the antibody results to come back before you go in and treat the patient, because ultimately patient comes first. So what is the significance? It proved autoimmune encephalitis is treatable. It gave us phenotypes and biomarkers to drive that treatment decision. It helped us to delineate the phenotype, so important to have that clinical phenotyping. It gives us investigative tools, although as you've already heard from Professor Dubey and others, essentially we don't depend on the investigation, but we go more by the clinical phenotype. And in pediatrics particularly, many of our patients are seronegative, so we don't often have that handle to help us make that decision. The immunotherapy, first line, is pulse methylprednisolone, as well as intravenous immunoglobulin and plasmapheresis. And because this is not a single one-time event, but they often persist, they need second-line treatment, sometimes with rituximab or cyclophosphamide, and subsequently they need maintenance treatments, which can range from rituximab to IVIG to MMF to azathioprine and cyclophosphamide. So that's a good example of something that's definitely autoimmune, and it's got clear treatment pathways. FIRES is another one, which is has recently become more apparent to require immunotherapy. And most of us know what this is: previously normal child, just a transient febrile illness, and then a stuttering, worsening course of seizures, developing to refractory status epilepticus, and then becoming obtunded and requiring intensive care. And we have many treatments that we use, but most of our anti-seizure medications are at most stabilizing or a stopgap. They don't actually solve the problem, because when we pull back on the treatments, often the status epilepticus will surge, and then we'll have to load on more anti-seizure medications to try to regain that level of control. And in desperate situations, we use halothane anesthesia, lignocaine, propofol, although not very long in kids, and magnesium sulfate. More recently, it's become more established that we should be using things like the ketogenic diet, as well as agents such as anakinra. Now, why use the ketogenic diet? You heard a little bit from Professor Banerjee. You know that actually the ketogenic diet is useful, and there are actually effects from the ketogenic diet which can be mediating anti-inflammatory effects. So the microbiome is modified by the ketogenic diet, and the microbiome itself also has effects that extend beyond the GI tract and to the rest of the body. And some of the ketone metabolites themselves actually block some of the inflammasomes which are created in the course of the inflammatory cascade. The other treatment we use for FIRES, anakinra, it's an IL-1 antagonist, and you have now got good evidence or good studies which guide us on what are the doses we should use. It's previously ranged from 3 to 13 milligrams per kilo per day. The duration is highly variable. We're very sure that we need to use it early, so the sooner we diagnose and FIRES and start treatment, the better. We still go through the escalation through the conventional treatments, but we should very quickly start to think about ketogenic diet and anakinra. And there is a consensus recommendation from the ILAE basically on the management of NORS and FIRES. And this is more by a Delphi consortium. So while it does definitely say we do need to start early, there are still question marks over the actual mechanism and the amount of evidence that we're basing our decisions on. So in actual fact, the guidance statement emphasizes that we should be collecting samples from our patients so that we can conduct basically mechanistic studies and determine what are the underlying mechanisms and the changes that goes through these patients when we put them through immunotherapy. Rasmussen encephalitis is actually the archetypal immune-mediated epilepsy, if you like to think about it, and there's very, very good evidence for the inflammatory aspects of it. In the interest of time, I'll just go a little bit faster. So there's clear histopathological features in the tissue samples that we take from patients with Rasmussen's that this is inflammatory, right? And here you can see they've got lymphocytic aggregation around the vessels, lymphocytic perivascular cuffing. And if we look at the histopathology, there's widespread vasculitis. If you do immunohistochemical studies on Rasmussen's patients, you find abnormal membrane attack complex positive, or C4-C8 complement is raised. Gene expression for inflammatory genes is elevated in those with an active Rasmussen's. And in terms of B-cell pathology, we can see anti-GLUR3 and anti-GLUR2 antibodies, which can be replicated in animal models if we give those antibodies to rabbits. And we see clonal expansion of B cells, which usually basically says that they are producing lots of antibodies. And the process that might be coming out of that is basically the GLUR3 might be directly stimulating those receptor ion channels, causing the excitotoxicity, or through complement-mediated excitotoxicity. In terms of T-cell-mediated activity, we do see increased peripheral cytotoxic T cells and CSF interleukin-6, increased MHC1 expression, which activates T cells, as well as infiltrating lymphocytes, which are predominantly of cytotoxic T cell type. So there's a rationale for using immunotherapy in Rasmussen's, and because many of these patients will have a somewhat stuttering course, it is quite difficult at the beginning for us to advocate for an immediate hemispherectomy. So oftentimes immunotherapy is used as a stopgap during the early parts of their treatment. And the goal of that is to try to arrest the loss of motor function, reduce the inflammation, reduce the atrophy of the hemisphere, and try to control the epilepsia partialis continua. There are fairly good regimens on how to treat Rasmussen's encephalitis. So this is above childhood onset and below adult onset. And so they differ only slightly in that all of them have methylprednisolone pulses. They do plasma exchanges, but perhaps in adults we use the oral steroids a little bit more sparingly because of the side effect profile. And we have seen studies and descriptions of immunotherapy usage in various patients with Rasmussen's encephalitis, doses ranging for this from 200 to 400 mg per kg per day, and the duration actually ranges very widely from 4 days to 46 months. Rituximab has also been used in Rasmussen's encephalitis, and this is a chimeric monoclonal anti-CD20 antibody, which essentially depletes your B cells. And I just wanted to say this, there was a previous study from the US many years back, which was put up on rituximab in Rasmussen's, but I was quite pleased to see a study from Pune not too long ago, and where they shared their experience of Rasmussen's and rituximab and their single center experience. But the sad thing is that despite all this stuff that we've done with Rasmussen's and all these well-reasoned regimens, the treatment response is often incomplete. So we delay rather than prevent progression and the need for hemispherectomy. You've already heard from Professor Dubey about this kind of entity of autoimmune epilepsy, which has been increasingly referred to. And it's very nice. We've got a paper from Shefali and Manavi on this as well in children. And basically, this is characterized as frequent severe seizures with at least one antineuronal antibody, inflammatory changes in the blood or the CSF or the brain, and perhaps autoimmune disease history. But I really concur with Professor Dubey in that we do need to be quite clear about what we're dealing with and not take any explosive onset epilepsy as being immediately taken as an autoimmune epilepsy. Now, it's true that autoantibodies cause imbalance between excitation and inhibition, and they target the neurotransmitter receptors, the ion channels, key enzymes, and the membrane proteins, and this can lead to a variety of changes which essentially lead to increased excitability, loss of inhibition, and then therefore refractory seizures. And if you look at the ways that the antibodies can actually impair the balance between key neurotransmitters, there are many. I won't go through this in detail, but you can look up this paper. And antibodies alone are not the only cause for this altered excitability, but there are many other factors. So antibodies, T cells, HLA, cytokines, as you've heard from Dr. Banerjee. So we already know that the decision for immunotherapy is clear in the severe encephalitis, fires type phenotypes. in patients who are perhaps a little bit less severe, we need to think about what is the appropriateness and the intensity of treatment, and we need to calibrate this according to their cases. And above all, we must not forget about well-recognized epilepsy syndromes and conventional treatment. So we mustn't be taking, oh, Lennox-Gastaut, let's treat that with just immunotherapy blindly, because there are very good treatments for this. The evidence for when and where to use the medications is still quite unclear. So there have been previous studies looking at COX-2 inhibitors, these are relatively milder immunosuppression, and those studies have been incongruent. They've shown that pre-treatment, before they give an animal an epileptogenic insult, has not been effective, whereas post-event treatment was, and that the dosing can affect the response. And furthermore, that the effects can be pro or anti-inflammatory. There have been human trials of ibuprofen and febrile seizures, but these were not effective. And seizures, sometimes, from our observations, you know that some of our patients who are refractory, most of them get worse with a viral illness, a febrile illness, but there's a handful of patients who suddenly stop having seizures or have improvement of their seizures when they're acutely sick. So the picture is far from clear on what that exact role inflammation plays in them. We do need better markers to guide our treatments, and our work, we've done a little bit on peripheral markers, and what we were looking at is we were looking at refractory epilepsy patients and comparing them with acute autoimmune encephalitis patients to see if we could identify either the same immune mechanism, which meant that we could treat them the same as autoimmune encephalitis, or whether there was a difference in the pattern of immune dysfunction. And we certainly found that the Th17 pathways appear to be, both of them show inflammation, but the Th17 pathways seem to be upregulated in childhood refractory epilepsy. So there are multiple mechanisms implicated in epileptogenesis. You've already heard very nicely about blood-brain barrier and inflammatory cell infiltration, microglial activation, reactive astrogliosis. I'm going to speed through this bit because you've had a very nice treatment from Dr. Banerjee about the importance of the blood-brain barrier and the neurovascular unit, and that actually this complex interplay between the cells and the blood-brain barrier and the cytokines and the antibodies all lead to increased excitability. Also, you know that now that there is actually no such thing as an immune-privileged brain, and we know that lymphatics actually penetrate all the way into the central nervous system. And in fact, mouse models have shown that bone marrow cells migrate from the bone marrow into the blood, through the meninges, and then onto the brain parenchyma and can differentiate into macrophages. So there's a clear communication of the peripheral and the central immune system. We suggest that high dimensionality analysis will help us to understand neuroimmunological dysfunction better. Traditional hypotheses with limited testing bands are actually, make it difficult for us to draw accurate conclusions, and it constricts our view of immune interactions. So high dimensionality analysis helps us to have a wider operation across the entire system and really get to grips with what's going on in these very complicated systems. We've done some work on our patients with resection for focal epilepsy, and using single cell transcriptomics and surface epitope detection, we were able to actually show that, of course, there is inflammation in brains of children with refractory epilepsy, and more so, we can see that there are microglia and infiltrating immune cells which show that inflammatory signaling patterns which resembles multiple sclerosis, i.e. it's the innate immune system. And if we did cellular staining of these patients, we show co-location of the microglia and the macrophages and the T cells and the neurons with IL-1B in drug-refractory epilepsy. So we've shown that there are inflammatory cells present in the brain of children with drug-refractory epilepsy, and that we see a signal for interleukin-1B. And we furthermore have gone through ligand receptor analysis to show that there are actually close interactions between those infiltrating immune systems and the neurovascular unit, or the blood-brain barrier. So refractory epilepsy seems to straddle the innate and the acquired immunity. Like we said, refractory epilepsy and new onset autoimmune encephalitis shares an inflammatory state, but Th17 is actually upregulated in this childhood refractory epilepsy. So there are differences in the approach that we would need to take from autoimmune encephalitis compared to refractory epilepsy. We've already heard to some extent about the pharmacological targets and the candidate treatments that there are there. Microglial and astrocyte activation lead to release of interleukin-1, interleukin-6, TNF-alpha. So all these inflammatory pathways. So, but it still remains to be seen where we should target our treatment approach. In the interest of time, I won't go through this. So just last thoughts on this is that the goal of treating inflammation in epilepsy should not be total suppression, which is kind of what we do with the severe cases, but rather appropriate modulation of the inflammation. We want proper healing, but not excessive suppression to the point of chronic immunosuppression or even promoting neoplasia. So we are currently in this phase with our program. We have about 300 over patients in a program we call the Brainiac program. And these are cross-sectional and longitudinal patients with epilepsy, ranging from self-limited all the way to drug refractory. And we are collecting immune samples, genomic samples, and collecting their clinical data. This is what our program looks like. So in summary, there are clear clinical indications for immunotherapy in specific severe epilepsy and encephalitis syndromes. There is roles for acquired immunity, but also innate immunity in these processes. High dimensionality analysis holds great potential to unlock the complexities of these inflammatory interactions, and we should be harnessing advanced transcriptomic approaches to really help us to elucidate this. There are still questions to be answered on the relationship between peripheral and central immune dysfunction, and we need to be careful in inflammation, not to overstep, not to give too much nor too little. And perhaps in the future, we will see clinical trials which are not merely the clinical trial, but also combine immunomics, as well as observational studies, which will combine the clinical phenotyping and treatment with conventional treatment with immunomics as well as genomics to give us a very complete picture of what's going on. I'll end my talk there. Thank you very much.
Great. So I think perhaps I can see some questions in there, and maybe I think I could answer the one by Paula Sarchi. So it's a very good question, which is what about earlier implementation of the interventions, like straight after a precipitating event, to try to capture or forestall the development of epilepsy during at the beginning of the latency period. And I think that's exactly the part that we need to do more research on. I think we are still unclear to some extent on exactly what is the right point of intervention. So we do need longitudinal studies to actually map what is the inflammatory processes that patients are going through from the onset of events and from the first development of epilepsy and through to development of refractory epilepsy. So that's a question which I think we need to answer with more work. Yeah, I think there's a question about mTOR and Rasmussen's encephalitis. So I think the time we gave our talk, a few papers were coming out just at that period. So mTOR, yes, you're right. mTOR is related or activated in Rasmussen's encephalitis. I think it's particularly the mTOR1 pathway. So definitely there is a role for that in there. Hi, Kamanwan. So nice question about tocilizumab in FIRES. I tend to use anakinra, I will say, because it's short acting and it hits very high up in the inflammatory chain. So IL-1. Tocilizumab is kind of has a very long half-life. So if there's any infections, you can't get it out. The risk of sepsis and comorbidity is quite severe. And it hits slightly lower down, probably, or down a branch, which is IL-6. I don't know what Div and I might have to add to that.
Very, very similar kind of approach to Derrick. I think preferably use anakinra. There's some studies from Mayo which have sort of demonstrated utility and benefit of anakinra. In some cases, we have tried tocilizumab, but most preferably anakinra.
Yeah, and I think there's a question about antibody against cytokine for improvement of seizures. I will say, I guess appropriate tool to the task. Like I said, in very severe cases of epilepsy, it's justified to use something like anakinra or tocilizumab. For anakinra with fires, I try to start within the first week or two, and the patients we've had probably take it for about 2-3 months, and then we are able to taper it off. The longer, I think the later you start, the more trouble, or the longer you end up being having to treat. So early is better.
There is one question on the CSF levels of the proteins, elevated proteins in DRE pathologies. Yes, there are reports which suggest that there are certain proteins with respect to inflammatory mechanisms which has been shown to be elevated in central in the CSF, and there is a pathology specific variation also. So yes, but yes, it is still not clinically being used, but there are reports which says that as well, not only in the patients as well as in the animal models also.
Yeah, so there's also another question on the gut microbiome. So I think the gut microbiome it's fascinating. It's also very easy to be misinterpreted. It's quite variable, so we need to be very careful about how we look at the gut microbiome. So you need good samples. You need a robust and standardized extraction protocol. Sequencing and identify of the genus and everything needs to be done in a very kind of robust fashion. And pairing that with the blood signatures could potentially be very valuable. I think probiotics, prebiotics is very premature to start doing microbiome analysis and start treating people just on the basis of that. I don't know what Div thinks about as well.
I do not have any additional thoughts.
Yeah, and in answer to the question you're talking about brainiac, we're doing cytometry time of flight on the patients, as well as we do analyze the cytokines and the chemokines, and we also look at the DNA.
And I think there was a question, Derrick, which might probably more relevant to your talk, I ended up answering on chat, was about treating autoimmune encephalitis, specifically at MDA with rituximab. The duration of treatment, is this a lifelong treatment that you pursue, or is it a sort of certain duration? And are there markers that you utilize to say when do we need to retreat the patient?
Oh, why don't you answer that?
So I think my response was usually not a lifelong treatment. We do it for about 12 to 18 months and then follow patients clinically, even though there is some CSF tighter data suggesting that can predict relapses. It's very hard to convince patients to undergo serial lumbar punctures.
Yeah. Yeah, I mean, I think agree. I think some of our NMDAR patients, it's usually around 18 months to 2 years of treatment. We have had the odd patient who relapses when we try to taper them. At the end of the day, if they start to relapse, don't leave them too long. We just quickly ramp them up back on treatment and try to get them stable.
And the more interesting data is from LGI1, where we had relapses even 5 years down the illness. And there's not much you can do to prevent those. And those are sort of close to 10% or a small minority of cases. But again, so we follow those clinically and then treat if the relapse does happen. There's a question about what assay do you recommend for autoimmune encephalitis? Is it always cell-based assay except for GAD65? So it depends. Great question, sort of more nuanced answer. It varies based on the type of antibodies. In most of the cases, the common assay which is utilized for testing like groups of antibodies is tissue immunofluorescence assay, where we take sections of mouse brain and add patient's serum and CSF to look for unique staining patterns. And that's usually a screening assay in most tertiary neuroimmunology labs. And depending on the type of staining that is noticed, it often leads to reflex to recombinant protein-based assays, which vary based on whether it's a cell surface antibody, it ends up being a cell-based assay. If it's an intracellular antibody, like you pointed out, GAT65, it ends up being an ELISA or a radioimmunoassay. There are certain antibodies which actually have a higher sensitivity and specificity just directly on the CBA, examples being LGI1 and then GABA B, etc. And these we directly go to the CBA in addition to kind of using the screening test to provide additional specificity.
Yeah, there's another question about like when to stop treatment in chronic cases. So again, I personally find it very important to try to phenotype them and see if they fit into a recognizable pattern. Because as you've heard, certain types of patients behave a certain way, right? Of course, the antibodies guide and the other kind of etiologies guide you on what is the kind of course of those epilepsies. And seizures and encephalitides. So it's kind of important to look at that. And then based on that context, we can try to, kind of guesstimate what is the right amount of time to treat. I will say in FIRES that there's almost no data I could find on the duration of treatment. Most of the data I could get from anakinra was rheumatological disease treatment, and there was very, very little on the optimal treatment duration for FIRES. So in the first instance, with our patients who started anakinra in the ICU, we had to leave them on the treatment, all of the ICU, intravenous infusions of anti-seizure medications for about 3 weeks, and we were actually guided by the EEG as a biomarker that the kind of the very angry, interictal, spiky kind of burst suppression settled to guide us when we could start to taper the intravenous treatments. And then the anakinra there wasn't really a guide I could find. So we did it over about 2 months, 2 to 3 months, and we just gently tapered the dose and then watched and kept tapering as we saw no resurgence of the epilepsy. I think there's an administrative question about lectures being available on YouTube. We'll have to defer to Jenna and Andrea on that one.
Sounds good. I think we can end the session, and then potentially there's going to be additional sessions organized by the ILAE along different topics.
Yeah.
Thank you all for joining.
Yep. Okay.